surgery. What do you mean by refractive surgery? Refractive surgery means that patient or the person under question, his vision is not normal. He or she has a refractive error. He or she has a refractive error. So once he or she has a refractive error, they want to get rid of the glasses. They want to get rid of the glasses. For that, you have to wear refractive surgery. So it's a very upcoming branch. Why? Why it's an upcoming branch?
People don't want to wear.
No, that's okay. Basically, the predominant refractive error nowadays is myopia. Is
Myopia.
And myopia is a refractive error where you can't see the distant objects clearly. Okay, you can't see distant objects clearly. And out of the estimates which are done worldwide, it's a major public health problem now. It's a major public health problem, and because of the increased use of mobile devices and digital devices, and over concentrating on real work like reading and this, and even genetics, so these all three factors are combined, and it is estimated in 2050, 50% of the world's population will be myopic. How much?
50%.
50%. So 1 out of 2 will be myopic, will be having myopia. So trends are already setting in, like Hong Kong, China, there the myopia is increasing. Just I have given you a background. Why it's so? Okay. So as you know, we have an optical system in the eye, where the rays of color rays of light get focused on what? They get focused on the macula. They will get focused on the. They get focused on the macula. Pointing or do we have pointing or no? No. This is macula here. This is macula here. So light will come, distant light will come and they will be focused on the macula. This is normal. This is normal. Then so this is the normal vision. So in myopia, what happens? The colors of light, what they do? They come from distance and they are focused in front of the retina. Why? Because the eyeball is long. Eyeball is long. Once something is long, why myopia happens? As the growth goes from puberty to adolescence, the whole body enlarges or builds, and the eye also increases its size. And because of the extra that stimulus, it increases out of proportion. It increases out of proportion, and that leads to the myopia. That leads to myopia. So then we have one more reflector where the color rays of light, they are focused because eye is small. Eye is small. So this is called hypermetropia. It's called hypermetropia. It's called hypermetropia. And the color rays of light are focused behind the retina. They are focused behind the retina. So one more is the astigmatism. One more is the astigmatism. What's astigmatism? Astigmatism is what? Astigmatism is that one medium is normal, other is focused in front of the retina or behind the retina. If it's focused in front of the retina, it will be called the myopic astigmatism. It will be called myopic astigmatism. If it's focused behind the retina, it's called hypermetropic astigmatism. So it can be both myopic or hypermetropic. So this was the astigmatism. Then one more refractive error is called presbyopia. Presbyopia. Because accommodation of the lens is lost in the adult age group, about 35, 40, and then we have to use the plus glasses. Then we have to use plus
Glasses.
or convex glasses like this. Okay? So these convex glasses give a clearer near vision. This is one more refractive error. It's called presbyopia. So we have four errors: myopia, hypermetropia, astigmatism, and presbyopia. These are the four errors where we use the refractive surgery. Then we have different classifications of the refractive surgeries. Suppose some surgeries are cornea based, some lenticular based, and some are combined. What do we call cornea based? Cornea based means what?
We increase like.
Any procedure is done at the corneal level. It is done at the corneal level. Lens-based means some procedure is done in the lens of the eye. Okay. Third is the combined, in which the lens-based is combined with the cornea. Okay. This is called combined. It's called combined. Other name for combined biopics. It is biopics. So again I will go back. So if we see coordination, there is one procedure called RP. That's called radial keratotomy. Radial keratotomy. Other is PRP. Other is LASIK. Other is epilastic. Other is LASIK. Other is concentric keratoplasty. Other is corneal laser rings. So these are the corneas. The lenticular rays are clear lens extraction for myopia, phakic IOL, more, but some things are more important. We don't have to tell you every detail about every procedure. The RP is obsolete now. It is not done now. Okay. The PRP is done. So PRP and LASIK. LASIK and PRP, they are done frequently now. Okay. So LASIK and PRP. LASIK means laser in situ keratogenesis, and PRP means photorefractive keratectomy. Then we have other procedures. They are just for nominal purposes, nothing much about that. Then the lens, we can do a clear lens extraction for high myopia. Okay. Then we have the phakic eye test. We can put a lens into the eye also to correct a refractive error. So then we use combination of two. Suppose we have astigmatism and we have a refractive error also. Myopia is astigmatism. We can put an intraocular lens, a phakic eye in the eye, and we can correct the astigmatism at the corneal level by LASIK. Okay. So we combine the two procedures for correcting that, and that's called biopics. Everybody take a picture of this chart. Just shoot it in your camera. There are few people, they can stand to each other. Done? Okay, let me go back now. There are some other procedures where something is put in the corner. Something is put in the corner. Like epicalophagia, some stromal tissue is put in the corner. Okay? Some corneal tissue, stomach of the cornea is put in it. This is generally used to treat aphasia. Then there are, this is called addition, there is subtraction. Addition means something is added. Subtraction means something is dissolved. So you have to be clear about it. If we add things, what will happen? If we subtract things, suppose in subtraction, we have PRP, LASIK, epilastic, LASIK, or anything. That will decrease the corneal thickness. That will correct myopia, hypermetropia. Okay, this is a subtraction. This is subtraction. What is the addition? Addition is putting the corneal tissue or any synthetic implant into the eye, into the cornea. That's addition. Then we have intracorneal lenses. condition. That's enough for you people in this. Then, how to do a pre-operative evaluation for the patient? What things we should look before going for the procedure? One is the screening, then is the history taking, then is the pre-operative examination, then is the counseling. Okay, so screening. What more we have to look for? We have to look for some systemic conditions. We have to look for some systemic conditions like diabetes. Why diabetes?
Diabetic retinopathy.
Just wait. You get up, you tell me.
Because there is the immune suppression, we reduce and then the discovery. Initial risk on trying to get to diabetes.
No, not really contraindicated. There is abnormal wound healing. There is abnormal wound healing. If diabetes is under control, no surgery is contraindicated. But if there is hyperglycemia is uncontrolled or it is not within control, then that's a related contraindication. So diabetes is one of the problems. Then we have the pregnancy and lactation. Why? Because pregnancy and lactation does what? It alters the refractive error. It alters the refractive error. So refraction can be wrong in pregnancy and lactation. Then we have other autoimmune diseases like connective tissue disorders, SLE, rheumatoid arthritis, so many those diseases. Why? Again, the healing and ulcerations of common in this. Okay? Then we have again these collagen disorders like Barber or Ehlers-Danlos. They will affect the what? The collagenization or the healing part of the body. Then we can have systemic conditions like HIV, tuberculosis, and one more important condition, that is the what? That's called herpetic corneal infection. Herpes virus. Herpes zoster or herpes simplex. Why that's important? Because once people do the procedure, they can get activated. They can get reactivated. And if there occurs a herpetic infection while doing a refractive surgery, it's a disaster. The surgery is going to fail. Then some drugs, again, as you know, the steroids, they affect the wound healing. Okay? As if you are doing any immunosuppressant that affects the wound healing. So it was the systemic contraindication. You again take a photograph of this slide. Okay. Next we have the ophthalmological contraindication. I told you one that herpetic corneal disease. Herpetic corneal disease. Other important is if you have dry. If you have dry, because these refractive surgeries cause dry. They cause dry. So that will increase. Then if you have very thin cornea, because we are ablating the cornea, we are decreasing its thickness. So if it's a very thin cornea, like a keratoconus, the procedure is contraindicated. Okay, this is called keratoectasia. This is called keratoectasia. Even if you have very high astigmatism, that will be produced by a keratoectasia. Once there will be keratoectasia, corneal will bulge, and it will cause high irregular astigmatism. It will cause high irregular astigmatism. So any such conditions like keratoconus, high irregular astigmatism, corneal ectasia, keratoglobus. Keratoglobus is what? Whole of the cornea bulges like this. Whole of the cornea bulges like this. You come here. You come here. Take here. Sit here. So cornea bulges. Whole of the cornea bulges. That's called keratoglobus. That's called keratoglobus. Then we have one produced marginal degeneration. Produced marginal degeneration. What's produced marginal degeneration? There occurs thinning of the inferior cornea. There occurs thinning of the inferior cornea. It produces high astigmatism. It produces high astigmatism. Again, they are all related to high astigmatism. There is keratoconus or there is a keratoglobus. You will not have astigmatism. You will have high myopia. You will have high myopia. Even keratoconus or pellucid marginal degeneration or any high irregular astigmatism, that becomes a contraindication. Then other eye diseases like uveitis, if the eye has hydrocyclitis or choroiditis or like that, we can increase the inflammation of the eye. We can increase the inflammation of the eye. That becomes a contraindication. Even some retinal pathologies, diabetic retinopathy, like that becomes a contraindication. Like RP and RD, or they are basically retinal degeneration. They are retinal, like somebody has retinitis pigmentosa with refractive error. If you correct the refractive error, his vision will not improve, still. Okay. So these are the contraindications, eye contraindications. So before we go for the eye examination now, what things we will check? First of all, we will check a visual acuity. Then we will check the refraction. Refraction you will check the two ways. One is the undamaged refraction and other is called cycloplegic refraction. That's called cycloplegic. Cycloplegic means we will put some cyclopentolate in the eye, 2%, 3 times, every 5 minutes, then we will check the refraction of the eye. We will see whether the refractive error is commensurate with the cycloplegic refraction. Okay? Then we have external examination. That you can do. You have to check whether everything is normal in the eye. Like you do a slit lamp examination, you see the lids, they are not infected. Why? Because the blepharitis or the mabular gland dysfunction, that can cause a nice infection in the lids. Once you do a surgery, it can infect the flap or it can infect the eye. Then if you have, suppose, some corneal opacity, that can affect the prognosis. Okay, then if you have uveitis, so these all things you will rule out by slit lamp examination. Then one more important thing is because these all processes cause mostly dry eyes. They cause dry eyes. So you will stain the cornea, you will stain the conjunctiva to see if there is staining of the cornea or staining of the conjunctiva. That is sort of a, you can tell that means patient has some sort of dry eye. Okay, so there should be absolutely no conjunctival staining, there should be absolutely no corneal staining. Then you will check the eye motility also. You can see the medial rectus, lateral rectus, superior rectus, inferior rectus, they are working normally. Superior oblique, inferior oblique. Then you can check the fundus examination. You can check the fundus examination, whether the disc is normal, retina is normal, macula is normal. Unless these things are not normal, you can do not go for a refractive surgery. Then you can go for some tests are important. One test is called pachymetry. What's called pachymetry? What do we mean by pachymetry? We measure the corneal thickness. We measure the corneal thickness. How much you get? How much is normal corneal thickness?
1.
Better. Anybody can tell me what center coordinate is and how much it is?
1 to 2.
Hmm?
1 to 2 mm.
1 to 2 mm. Your grossly doubled and quadrupled. It is. Okay, it is 520 micron in the center. It is 520. Oh, बेटा क्या बोला मैंने? 520 what? Micron. Huh? 520 micron in the center, and the periphery is 600 or 625 or 650 whatever. So center is the same, periphery is moved. So 520 micron is almost half of an mm right now. How much? Half. So you have told 1 to 2. That's a very gross error, I think. Okay. So this is only 0.5. You can simply remember 0.5 or 520 micron or 520 micron. And other is peripheral is 620 or 625 micron. Other is the topographic analysis. Other is the that's called ARP scan. That's called ARP scan. What does it do? That measures corneal curvature. This is anterior curvature of the cornea, posterior curvature of the cornea. Then that sees the calorimetry values. How much is the vertical curvature? How much is the horizontal curvature? That's measured in diopters. So all these things can tell about the contour of the cornea. Okay, it's thickness, its anterior curvature, its posterior curvature, its calorimetry, and its curves. These are all done by topography. It is done by topography. Scientific diagram. Okay, so it's measured. That probe is put on the cornea, and it measures from epithelium to the endothelium. And measurements I have told you. Off scan is seen like corneal topography, nothing much about this. Epithelial means that some tissue in the cornea. Suppose we put some cornea has been taken from some dead body. We put take a part of the stroma and we add to the cornea. Generally, it was used previously in aphakia, but this is not nowadays used. Radial keratotomy. This was previously once we were, I think, doing post radiation. Even before that, there was one surgeon from Punjab coming here. He had a lot of patients of radial keratotomy. This is given in, suppose it's a cornea. So it's a cornea. You are giving incisions. You are giving incisions by blade. You are giving incisions by blade. Just I will show you how. Slide it. Suppose it's a cornea. Suppose it's a cornea. So you are putting incisions like this. Like this. Like this. Like this. Like this. They are half this cornea. They are half this cornea. So once they are half this cornea, what happens? The central curvature flattens. Central curvature flattens, and it corrects myopia. It was later on abandoned. Why? Because it makes the cornea weak. And there is a chance of perforation. Of the cornea on these scar marks. So then it was abandoned. Then leave this. This is called astigmatic keratotomy. Suppose your vertical meridian is, suppose this is cornea like this. This meridian is more steep. Horizontal is flat. You will make an incision here in the cornea, at the periphery, at the limbus. It will relax this curvature. It will relax this curvature. And this is called astigmatic keratotomy. Suppose somebody has one diopter astigmatic, the vertical curvature is more So you will give an incision here 3 mm and you will give it 3 mm here. It will just address that one time. So in smaller kinds of astigmatism, astigmatic keratotomy is an option. It is an option. So we go now to two primary procedures which are done worldwide this time. Remember these and be now attentive. One is called photorefractive keratectomy. What's called? Photorefractive keratectomy. And other is called LASIK. Other is called LASIK. So what is the difference between photorefractive keratectomy and LASIK? I'll go first with the LASIK because this is the more common. This is not, then I'll come back to PR. Okay? So LASIK, what you do, you make a corneal flap. You make a corneal flap. Corneal flap is made at what level? Anterior strome. So that's made with microkeratosis. That's made with microkeratosis. That is a hinged flap. That's a hinged flap. Hinged means what? At one point that's attached. At one point that's attached. Suppose I make this cornea. You make it flap here, but it is attached here to your bone. The rest it is attached. It is taken up like this. So hinge means because it's attached at one point. It's attached at one point. This is called hinge. So here you can see. Here you can see that this flap has been raised. And it's hinged here. Okay? So what is the procedure we do in this? In this, we do two procedures. One procedure is that we are doing a flap. We are making a flap. Number second procedure is that we are applying a laser. We are destroying the corneal tissue. So first, if we make an incision in the cornea, what things are used for making an incision? You can use a microkeratin. Then we can use a laser. What type of laser is used to make incision? Femtosecond laser. That's a femtosecond laser. Once we make the incision, we raise the flap, then we apply the excimer laser. We put the excimer laser. What's excimer laser? That's the argon fluoride laser. That is in the ultraviolet range. 193 nm range. The femtosecond laser is in the infrared spectrum. That's around 1050 nanometers. But then that makes the incisions of the flap. So you can do mechanically by microkeratin, or you can do by laser. That's the femto laser. You can make a flap. This I told you almost. Then we have the ablation bar. So laser ablates the cornea. This excimer laser ablates the cornea. Can anybody tell me what are different procedures lasers are used? What's your name? You are you. What's your name? Huh? Isha, tell me. How the lasers, what are the effects of lasers? There are three mechanisms. How many? Three. You sit down. Anybody can tell me those three mechanisms? You can tell me? No? Keep your phone here. Keep your phone. There are three mechanisms. How many? Three. One is called photocoagulation. What's called? Other is called photoablation. It's called photoablation. And third is called photodisruption. That's called photodisruption. What is photocoagulation? Photocoagulation is coagulation of protein. That is coagulation of the protein. That is used in the retina. Once you have diabetic retinopathy or like that, you have multiple vessels, new vessels of the retina to destroy it or to destroy the peripheral retina. That's called photocoagulation. Photoablation is done by this eczema. It ablates. It destroys the tissue. It destroys the tissue. How does it act? Basically, in the collagen, there are carbon-carbon bonds. There are carbon-carbon bonds. It breaks them. It breaks them. Okay? And tissue is destroyed. Ablated. Third is the photodisruption. What is photodisruption? Photodisruption is done by peptide or by YAG laser. What it does? It gives high energy. And what is this high energy? With that there is a noise, acoustic noise. There is an acoustic noise, or a thunderbolt, or a thunderclap, or lightning bolt. And because of thunderbolt and this, what happens? The energy goes. It removes the electrons from the tissue. Okay? The particle expand, and there is a bubble formation. And that disrupts the tissue. Okay? That disrupts the tissue. This is done in YAG laser, or once we have posterior capsular opacity in post-cataract surgery, we can use the YAG laser for cutting that. We focus the beam in the anterior vitreous, and because of that noise or that thunder, the posterior capsule is ruptured. Okay? That opacity goes. Here, how it is used? Because once we are making a femtosecond incision, a corneal flap, we are using a corneal flap. The flap, it cuts the tissue. It cuts the tissue out of this noise, and there is a bubble formation. That can create an opacity like this. But once the gas goes, everything clears. That's called also plasma. Or ionization. Photoionization, photodisruption, plasma, thunderclap, lightning bolt, they are synonymous. So this is the background I have given you. So, one thing, there are some modifications of elastic technique. One is we are using a microcamera. Other is making it incision. Then we are using a femtosecond laser. That's better than manual microcamera. Then third is that's called wavefront. Wavefront lasers. What is the difference between lasik and wavefront lasik? In the lasik, they carry the refractive. But these patients can have glare. They can have glare. Don't do anything. They can have glare in the light or halos. In the wavefront, they take a whole image of the eyeball, of the cornea, and wavefront technology is called higher order aberration. They don't have halos, they don't have glare, so that's the added advantage of wavefront technology. What is wavefront technology? That estimates these small errors. Okay? Small errors in the cornea, which are not picked by the glasses. Okay? What are these called? Aberration. They are called higher order aberration. It has a barometer in its area, and that does the 3D of the eye, 3D of the cornea, and then what it does? Then it selectively aberrates the cornea. Somewhere it aberrates less, somewhere it aberrates more, and that adjusts to the higher order aberration. And this is called wavefront length. Did you understand? So we can have simple LASIK by microparameter, we can have laser incision flap by trapdoor, or we can have a wavefront LASIK by wavefront technology. By wavefront technology. Okay. So how we can select the patient? So somebody has myopia. There's a 5-year-old child. He has -4. Should we go for LASIK? No. Why? It should be stable. And when does it become myopia stable? Between 18 to 20 years or even more. But the criteria is it should be stable. It should be stable. And that's for at least minimum 2 years or 1 year at least. 1 year or maximum 2 years. It should be stable. It should not change. Suppose somebody is -4, it should be stable over a period of 1 year or 2 years. Okay? Generally people do LASIK above 18. Above 18 years or above 20 years, like that. 18 is the minimum, I think. Then there are some things I told. There are some limitations. Because we are cutting the tissue. Too much of foreign tissue cannot be done. You understand? What is the reason? Suppose 500 microns. Suppose we abrade 300 microns. There will remain only 200. What will happen? No. Character ectasia, character cones type. Corneal bulge form. Okay? Corneal bulge form. Character cones. Okay, it's called post-refractive character ectasia. It's called post-refractive character ectasia. So, but here I was correct. Here it is written -15. It's not -15, it's -8. How much? -8. So, LASIK can be used up to a myopia of -8. Up to -8. Hypermetropia up to +5 +6. Your estimate is also +5 -6. Then you know that CCT, no light, no sight of. CCT I have told you, we have a corneal thickness which should remain. Minimum corneal thickness which should remain corneal bed after ablation. That should be 280. How much? 280. Suppose if I lift the flap, now we are ablating the cornea. Remaining bed should be 280. How much? 280. Beyond that we cannot. Suppose somebody has thin cornea, 300 or 400 micron. Myopia LASIK cannot. You have to understand this. And what is the relationship between the cutting of the tissue and the dioptric cornea? Suppose somebody has 1 diopter of myopia. How much tissue should be destroyed? Normally they say if you have 6 mm flap, how much? 6 mm flap. If we destroy 12 microns, how much? 12 microns, it will be correct to 1 diopter. How much? 1 diopter, 6 mm flap, 6 mm flap, 12 microns and 1 diopter. Suppose somebody has 5. Suppose somebody has 5. That means 60 microns will be ablated. that can find diopters of myopia. So this test can be done in myopia, it can be done in hypermetropia, it can be done in astigmatism. How it can address all these things? Because in myopia the central cornea is steep. So you apply it will flat. Okay. In hypermetropia central cornea is flat, so it will just the mid peripheral, it will act on the mid peripheral. It will act the laser will be it will cause ablation in the mid periphery and it will make the center more. Did you understand? In the myopia, the central cornea is ablated. And that is the myopia. In the hypermetropia, mid-central cornea is ablated. That makes the central cornea steep. And that reverses the hypermetropia. So astigmatism, you will have a relative. One meridian will be done more, other meridian will, suppose horizontal meridian will be done more, vertical will be done less. Like that. So, these operative procedures just naturally, suppose you have to do a marking, then this is the suction ring. This is the suction ring. Then you have the suction ring, then you have the keratoon, manual keratoon. But before that, you make the patient slightly comfortable. What you will do? You will just confirm the eye, which is to be operated. You will put some anesthetic, proparacaine, okay? Give some diazepam or some sedative to the patient. Then you will apply the speculum. Then you will apply the suction ring. Then you will make the flap. Then you will bring the eczema laser. Then you will put that eczema laser. You will do a what you will do? You will ablate the cornea. Then you will give a wash. Then you will put the flap back. That's the procedure. So technically it is not that difficult. Technically it is not that difficult, but only thing is the cost of the machine. Only is the cost of the machine, and once you have a high cost, then it creates a problem because you need a more number of patients to be done. So this was about this. Laser keratoon, I told you, once we are making a flap, then what will happen? It can be done by laser. It can be done by, that's called femtolaser. And once it is done by femtolaser, that term is called intralaser. That's called intralaser. So what can be the problem with this? What can be the problem with that? There can be one problem that first of all, it can lead to infection of the eye. Okay, infection of the eye. Then it can lead to, suppose, flap-related complications. It can lead to flap-related complications. Suppose there is a hinge. If you have very flat cornea, hypermetropic flat cornea, you will have a free cap. You will have a free cap, which is detached from all sides. There will be no hinge. This occurs in flatter cornea. In which keratometric is less than 40 or 41. A hypermetropic type of cornea. Then if you have high myopia, very distant, then what can happen is that there can be flap perforation. Once the central cornea is dipped by this, it will cut here, it will not cut the center, it will cut again, and it will cut again. Okay, so central cornea will not be cut. Did you understand it, or I will show you? I will show you it. Suppose this is a cornea like this. This is a cornea like this. Once we apply a suction or like this, we can dig the cornea like this. In high myopia, in which there is high characteristic reading. So once the ray will go, it will go like this, it will go like this. So this area is not used. Oh, Mr. Come forward, you come forward. आपको बोल रहा हूँ आप आगे आइए when you are talking what's your problem you are not understanding what's your name so this is called perforation of the flap this is called perforation of the flap these are ways because perforation of the flap leads to very dangerous and gross bad results. Okay? So the prognosis in perforated flap is very good. So what else is this called? Like one more thing I have told you, if we abrade too much, it can cause keratoconus. Okay? And once the next day the patient gets up, he or she can have very good vision, but she can have again glare halos during night. Okay, this is one more problem in these patients. Suppose now we are making flap, what it will do? It will cut the corneal nerves. It will cut the corneal nerves. That leads to the dry eyes. That leads to the because corneal nerves are very important for maintaining the tear flow. It's a reflex. There's a reflex. That's why in most patients we have what? We have dry eyes. We have dry eyes because of this cutting of the cornea. One more complication in them is called diffuse interstitial keratitis. That's called diffuse. Suppose some powder of the glove or some material or something remains between the flap and this. Once we put the flap back, then what can happen? It gets an immune reaction. It gets an inflammatory reaction, which can be, that's not an infective. That's not an infective. Then steroids are given for that, or antibiotics can be given for that. And last I told you, endophthalmitis. That is the biggest concern. If the flap gets infected by medullary gland, lid infection, which was previously existing, that can lead to what? That can lead to endophthalmitis. Infection can separate inside of the eye and it can destroy the vision of the patient. That's called endophthalmitis. So these are the complications of this last procedure. So one more problem in this is because the flap-based procedure. It's a flap-based procedure. What can happen? If somebody has some go back. If some girl has done a lesson and now she wants to be a boxer, it can destroy the film. Or somebody do a martial arts, kicking. You understand? Or punching or something that can destroy the film. So these are related contraindications. So you have to ask the professionals. You have to ask them. If somebody is a boxer, somebody is doing a martial art or any aeronautics sports, this last procedure is contraindicated. Suppose somebody has done it, it is normal. Now she has gone for the boxing or the martial art, and that goes away. Everything is gone. So these are the complications of this test. Now we go to the PR. PRK and LASIK, what's the difference? In the LASIK we keep the epithelium and stroma intact. We make it flat. In PRK we debride the epithelium. We remove the epithelium. Then we apply the laser. That's called photorefractive keratectomy. What is that called? Photorefractive keratectomy. That's PRP. Huh? So what is the problem with it? Number one, because you are removing the epithelium, patient next day has a pain. Next day has a pain. So pain is more a feature of PRP. Okay. Then patient is discomfort. That's no side talks. Who is talking? Patient is very discomfort in the eye. Okay. Number four, that patient does not recover fully next day. Last view, patient recovers fully next day. But in PRK, there is a corneal haze. There is a corneal haze which can take almost a 1 week clear. What are the advantages of PRK over LASIK? If the cornea is thin, less than 400 microns, it can be done. We are not, because we are not making it flat. We are not making it flat. So in thinner cornea, it can be done. One more procedure is called LASIK, L-A-S-E-K. LASIK, S-E-K. What is the difference between LASIK and LASIK? किसी को पता है ये और सी में क्या क्या वहाँ बैठा बोलो बैठा कहाँ if you know tell me get up without appearance what's less हाँ XC2 means what it's not XC it's not XC it is only the flap base because it's backward LASIK जो है LASIK in that flap comprises of only of epithelium. It comprises only of epithelium. Okay, that's it. There is one more term that's called epilax. That's called epilax. In that also the flap is already comprising of what? Only of epithelium. Only of epithelium. So these are the two terms. LASIK and epilax. Remember this, because somebody may ask you this thing. So one is LASIK, L-A-S-I-K. It is where the flap that comprises of epithelium only. और epithelium को कैसे करते हैं? How does it be ablate? By alcohol. By alcohol. And other is epilax. तो उसमें क्या होता है एक प्लास्टिक होता है one plastic layer sort of plastic carrier one sort of a plastic carrier which raises the epithelial flap. So this is it. So I have covered your LASIK, I have covered your PRP. Now we go to other procedures. This is one more complication. Flap strain. Flap strain. There's a bigger strain in the flap or minor strain in the flap. These are micro strain. These are the flaps, but what I want to show you, straight. They are straight, yes. They are straight. They are straight. So, one of the complication is called epithelial ingrowth. What's called? Epithelial ingrowth. What's epithelial ingrowth? The epithelium goes through the incision. It goes through the incision. And between the flap and the stromal band, there is epithelium growing. It can happen in cataract procedures also. It's a very dangerous complication. It's called epithelium growing. Again, you have to then raise the flap, remove the epithelium growth. That's a cumbersome procedure. Just for infectious keratitis, keratoectasia, I told you. Glaucoma, LASIK and plastic, I have told you. PRK and advantage of PRK over LASIK. And LASIK advantage over PRK, that I have also told. In LASIK, next day it is a O vision, 6 by 6. You understand? In PRK, it is not like that. It takes a week. Now there are modifications of this LASIK. There is a modification of the LASIK. That's called lenticule extraction. There are lenticule extraction. There are two procedures for that. One is called smile. One is called smile and the other is called silk. Silk and smile. These are two different machines. Yes. But the procedure is same. You make an incision in the superior cornea. You make it by temporally. One anteriorly, one posteriorly. Between the two, that lenticule is removed through that incision. This is called lenticule extraction. This is called what are the advantages? One, there is a small incision. There is a small incision. Number second, there are no flap related complications. There are no flap related complications. These are the two advantages of this. And number third important advantage, there will be no dry eye. Because we are not making a real flap. You understand? So dry eye will not be in smiles or silk. Okay. Every you go, you do notice. We have then one more thing. So I have told you about PRC, I have told you about LASIK, I have told you about smile, I have told you about silk. Then one more thing is, suppose somebody has a high astigmatism. Somebody has a high astigmatism. We put some rings like keratoconus. What is that called? They are called intacts. That is called intacts. So in tunnel we make in the cornea on one side and on the other side. Then we make plastic rings in them. Okay, they are called intact things that address to the astigmatism. That address to the astigmatism. One more is called allogenic rings. They are called allogenic rings. In that we put some corneal tissue strips in there. Okay, even that corrects the astigmatism. Then we have some basic, one more problem is the presbyopia. That's the presbyopia. What we do is that we do a procedure that is called conductive thermoplasty. Conductive thermoplasty. And sort of a radiofrequency thermal burns are given in the stroma, in the mid periphery of the cornea. That corrects the presbyopia. That corrects the presbyopia. These are the, I think, these are the, have you seen this? This is the plastic rings, intact. These are intact rings which are placed in the cornea. You can see here, these are, they are placed in the cornea. Okay? So they are placed in the cornea. Okay, let us go ahead. Most important thing is coming. I have to tell this. I will tell this that I know. Okay? I will tell you the short. This is called phakic intraocular lenses. This is called phakic intraocular lenses. Photophakic intraocular lens. We place the lens in the eye. We place the lens in the eye. Where lens placed? That is placed in the sulcus, behind the eyes. That is placed behind the eyes. There are some criteria for that. You have to make with the white to white diameter. What? White to white limbus white to white for sizing purpose. That the anterior camera depth should be minimum 2.8 to 3 mm. How much? Why? Because these lenses can cause endothelial decompensation. They can cause endothelial decompensation. They are generally put in very high myopia, whereas it cannot be done. Like -18, -15, -20. And one more thing is they have vault. They have a vault. Vault means between the natural lens and this artificial lens. There should be a gap. There should be a gap. That's called vault. If there is no gap, what can happen? It can cause cataract. It can cause that cataract is generally anterior cataract or that's the nuclear sclerosis. And they also can cause glaucoma. They can also cause glaucoma. How they can cause glaucoma? If the sizing is not proper, they will not fit in the sulcus properly. Then they can cause bulk of the peripheral eyes, which can obstruct the angle. Which can obstruct the angle. These are different, but mainly there are two types of. One is by star surgical. One is by star surgical. That's called columnar lens. Other is this simple hydrophilic type of material that's done by Indian companies. Columnar is not done by Indian companies. That's the point. Indications I told, main indication is very high myopia. Okay? Even hypermetropia can be also done. Sizing I told you. These are different types, these are not relevant to you. Don't worry. So bioptics I told you, in which we put in this class, lens we can do a order bridge procedure with a lens based surgery. Suppose we do a phakic IOL, and we do a PRP. That will come in the bioptic.